Good day, and thank you for joining today's webinar. I am Sherilyn Francis with the National Center for Primary Care, and we welcome you to Topic 1 of our integrated webinar series. We invite you to connect with us at our website, www.primarycarematters.org, and we will be live tweeting during today's webinar. You can live tweet us at PriCareMatters using hashtag Opioid Policy. The National Center for Primary Care is located at the Morehouse School of Medicine. The NCPC is a national resource for encouraging doctors to pursue primary care careers, for making primary care practice more effective, and for supporting primary care professionals serving underserved areas. The core principles of the NCPC are access, effectiveness, and equity. Today's webinar is brought to you by a collaboration through two programs in the NCPC. The Southeast Addiction Technology Transfer Center, and Program 2 is the Transdisciplinary Collaborative Center. The objectives for today's webinar are to identify the impact of recent opioid prescribing guidelines and protocol in various states, to identify the impact of recent opioid prescribing guidelines and protocol on a national level, to examine the impact of opioid addiction on the delivery of care to patients, especially with substance abuse disorders, and to evaluate the policy recommendations that can help to reduce opioid addiction and other substance abuse disorders. I now present to you today's webinar entitled, Are Policies for Reducing Opioid Addiction Impacting Care in Your Community or Clinic? Presented by Dr. Susan Blank, President of the Georgia Society of Addiction Medicine, and Dr. Courtney Yarborough, Assistant Professor, Emory University Rollins School of Public Health, and moderated by Larissa Smith, Research Associate, SATCC. In compliance with ACCME guidelines, none of the presenters have financial or other relationships with manufacturers or commercial services discussed during today's educational activity. We're going to begin today's webinar with a poll question. How do you characterize the impact of opioid policy on your professional, community, and/or clinical practice?
Thank you so much. I have to tell all of our listeners I very much appreciate the questions that were already pre-submitted. Lots of thought-provoking and really good ideas. Hopefully we'll be able to cover some of those. But today I'd like to take a look at what the problem is, how different state and federal organizations are working to try and minimize the impact of the opioid crisis, take a brief look at some guidelines, look at the impact, or unfortunately the lack thereof, of these guidelines, and review some reasons to take time out and invest in the effort to monitor your patients and refer them to treatment. So we know that the perfect storm happened in the late 1990s when we had a combination of direct-to-patient marketing of medications and pharmaceuticals. We had pharmaceutical companies developing new types of long-acting pain medications, and the marketing that went along with these medicines to primary care doctors in particular had to do with the fact that people can't get addicted. And if you have, quote, real pain, unquote, you're not going to have a problem with it. So primary care doctors, as they've been forced to over the last few years, assumed another role, which is providing pain management. As we began to see institutions like the Joint Commission and other agencies making pain the fifth vital sign, pain became a real issue. And on that pain scale of 0 to 10, if you scored a 4, then it was suggested you consider using opioids. So all of this came together to begin to develop what we see as this crisis, which is in 2015, drug overdoses accounted for 52,000 U.S. deaths, and most of those, 63%, involved in opioid. It's a growing problem for our women and someone that you should pay particular attention to in your practice, because women are more likely to get a prescription for opiates, benzos, and other medications than are men. We know that the way in which healthcare providers write prescriptions has varied from state to state. Unfortunately, I'm in Georgia, and while we're not the worst, we're certainly not among the best. We know that in the South we have a significant problem with prescription opioids in general and with illicit opioids specifically. Because of this, a number of states have made an effort to take some action to decrease the prescribing. Now this, and we're going to talk about this a little bit later as well, but our whole goal in the United States from the time of prohibition on forward has been we're going to decrease the supply of these medications or substances that are being misused, and out of that we're going to fix our problem. Well, there are lots of supply issues, and a number of states have taken some action, and you can see here some of the results. In fact, in 2016, there were 536 bills presented in 47 of our 50 states addressing this issue in particular. In Georgia, we had a number of laws that dealt with our PDMP. We removed the PDMP from being under law enforcement and moved it to public health. We allowed a wider number of people to access it, though the physician is still responsible for any information that is obtained and misused. Many states have been working really hard on regulating pain clinics. Georgia as well has some recent laws regarding this, and I have some references here. You can check those out if you're interested. Also, Georgia made some changes, not legislatively, but through the Physician Practice Act, requiring that patients who are going to be seen by a primary care doctor or any specialist for more than 90 days worth of prescriptions, whether it's a Schedule II or a Schedule III, for the treatment of chronic pain, they will need to have specific documentation in their medical record. They'll have to see the patient at least every 3 months, and the treatment plan must recognize and document how the prescriber is going to be monitoring for the safety, including pill counts and drug testing. Additionally,
Dr. Blank, you bring up a really good point. I think you really hit home that every state has different policies to address or to combat this issue. So I guess I'm wondering, and it sounds like you feel like Georgia might not be doing enough. So I guess I'm wondering, from your vantage point, what are some of the things that your personal recommendations, kind of as an area expert around what every state could possibly do that would make an impact, you know, a short-term or a long-term impact on the opioid epidemic?
That's a good question, because I think there's a lot that we can do. Most healthcare professionals that I know are very interested in the data. They make their decisions, they make their judgments based on data. And while we have a lot of guidelines, we don't have a lot of data about the impact. More and more states are being able to take and have access to the data from their prescription drug monitoring programs that can really highlight and document what is being prescribed by whom, where, who's using it, who's paying cash, who's using insurance, these kinds of things to help doctors understand. So wider access to the data. I think we're also missing focus on a number of groups that have not really been brought into the loop in terms of education, which would include groups like dentists. When I practice primarily pain management and addiction, and one of the things that's very clear to me as I do an addiction history on my patients is their first exposure, now not their first use and misuse of drugs, but their first exposure to these opioids in particular are coming from dentists. And we have not brought those groups in to look at this. So having a more statewide approach and federal approach that brings together all of the prescribers and all of the interested parties, and I know one of the questions was about expanding the community. And this is really important. Our Medical Association of Georgia has brought together insurers, Medicare, Medicaid, We have brought the Nursing Association, the Dental Association, our private training facilities, medical schools, nursing schools, dental schools, providers from all of the organizations that have an interest or responsibility in this area for our Think About It campaign, which is think about it before you prescribe it, and then to the public, it's training on think about it before you take it. So there's a lot that can be done and a lot more that we can do here in Georgia and I'm sure in other states as well. One of the important things to look at is on this slide. If you're wondering what your specific state is doing or not doing, there are some information here updated as of 2016. Hopefully some of these have also updated with the latest legislative sessions about what the states are doing in particular. The guidelines have come out as another way in which organizations that are stakeholders in this problem are trying to look at what are best practices. The CDC certainly came out with guidelines specifically directed towards primary care. The guidelines I'm most familiar with are the American Society of Interventional Pain guidelines, and I was one of the contributing authors for this. These guidelines, and I'm not going to go into detail, but you can look at them. They're very similar. A lot of the key principles are here. Carefully assessing the patient, making sure that you use the minimal amount that can be most effective for that patient, monitor them very carefully, and look not just for improvement in pain, but improvement in functioning. Asking the questions as you go along, as you're making that decision each time to write a prescription, asking the question, am I really doing my best work here? Is the patient improving? Are they able to go to their kid's soccer game? Are they more functional at work or at school? And am I helping them with minimal side effects and minimal risk? And is there any aberrant behavior that might lead me to think that this person might have a problem and then referring them on for treatment? When we look in 2013 at who is needing this education the most. Now, certainly on a doctor per doctor basis, pain management, emergency room, and other groups are the groups that are, but we know that emergency room anesthesiology and pain are the groups that provide the most per doctor prescriptions. But when we look at who is really prescribing the most, primary care, internal medicine, and physician extenders are prescribing many of these medications and resulting in some of the difficulties. When we look at what has been the impact on pain specialists, now as a group, these folks are probably the most trained on this issue of proper prescribing, but we can see that there has been a big percentage, the brown, that have really not changed their practice. And in some cases, fortunately, the non-opioids are actually being prescribed more frequently. But when the National Safety Council went through and actually polled U.S. prescribers about how compliant they are being with the CDC guidelines, one of the things that we find is that a majority of the doctors not in compliance. And number 3 is of concern to me that most all doctors and prescribers have found someone in their practice or know of someone who is pill seeking, and yet they're not referring them to any kind of particular treatment for this. And when I ask people what's the problem with the new prescribing guidelines, what's the trouble with checking the PDMP, it's the hassle factor and the fear that the insurance companies will use the guidelines to deny payment. And they don't know what to do if they have a problem. And this is a big, big question. What do I do if I have someone who I think has a problem? Well, UCLA did a very interesting study from 2014 2006 to 2015. And they looked at all the patients that were being treated in their facilities, not in addiction treatment, but in primary care and specialty care. And one of the things that they found is that they had over almost 2,600 patients that were identified that actually had a diagnosis of opiate use disorder. And out of those, 465 people died. 18% died. They died from a variety of drug-related problems, overdoses, cardiovascular disease, and other kinds of issues related to their use of tobacco or alcohol. This is a big, big problem because, again, we've spent so much of our time, our money, and our budget on looking at ways to decrease the supply. And yes, we need more education. We can do a better job. But of the $36 billion that's spent by state and federal agencies each year on the war on drugs, one of the things that we find, unfortunately, is 96% of that money is spent on law enforcement, less than 2% spent on prevention and treatment. This is not okay, and this is a big problem because many of these patients, even when recognized as having opiate use disorder, were not being referred for treatment. They are dying at an alarming rate, 10 times faster than the regular population when matched for sex, age, and diagnoses. This is a serious problem, and we know that addiction is a treatable illness. We can do something about it. Healthcare providers can be on the front line, not just of monitoring, but of also referring to treatment, and doctors and healthcare providers can get their DATA 2000 waivers to begin providing buprenorphine as a treatment modality for patients in their practice. We need to do something.
So along those same lines, Dr. Blank, you bring up some really good points, and I want to ask, I've been reading a lot, and there's a bunch of kind of qualitative studies coming out of late talking about the clinician-patient contracts around opioid use. And like you said, a big chunk of the money to kind of combat this opioid epidemic we're seeing is going towards law enforcement. But I was wondering what you're hearing and what you know to be true of how effective the clinician-patient contracts are.
Well, I think they're very effective if they're used properly, which is they give an opportunity for the doctor or the healthcare provider to have this conversation with patients, to talk to them frankly about the risks, to look at what are some of the telltale signs, what are some of the things that the doctor is going to do or the healthcare provider is going to do to monitor the patient, and what are going to be the consequences if there is aberrant behavior. This allows the patient to ask questions, the doctor to emphasize how serious this is and that it's a team approach, and if there is a problem, that there are some other solutions. So when used appropriately as a way to educate the patient and to hold the patient and the doctor accountable, I think they can be very effective. And many of the pain management doctors use these a lot, most of them do, and they find them very effective also as a way to be able to say no, because that's one of the difficulties. Patients have expectations, and unfortunately it's a difficult conversation. But if you can have it before there's a problem identified and speak clearly about expectations, often it reduces the need for further discussion, and the patients know where things stand.
Thank you.
So in conclusion, I would just like to make sure that people understand the need for screening, the benefit that that can have, and that they can reduce. These same patients from the UCLA study, if they were referred to addiction treatment programs, they were half as likely to die. Still a lot of people dying, but it's a dramatic improvement in the death rate. And unfortunately, most of these patients were not referred for addiction treatment, even when they were given that as a primary diagnosis. Too many people are still dying. So thanks for listening.
Okay, I'm Courtney Yarbrough. I'll jump in here. I'm going to tell you something about a research study that I've been working on and that was published recently, looking at a particular policy in response to the opioid epidemic. And Dr. Blank touched upon this. It's prescription drug monitoring programs, and looking at what their impact is on prescribing using Medicare Part D data. As Dr. Blank eloquently explained at the beginning of her presentation, of course, we have an opioid problem in this country, and I won't go back over the specifics except to just point out that we've had almost a quadrupling in the death rate of opioids since 1999, and last year, or in 2015, there were 33,000 deaths from opioids overall, and almost 26,000 of those were from prescription opioids. So prescription opioid painkiller addiction is a major problem, and I'm also in Georgia, so I wanted to point out some of the Georgia statistics. And Georgia is below the national average in death rates from opioid overdose. There were 858 deaths in 2015 in Georgia, and the state ranked 33 among the 50 states. And just in case you're curious, the states that had the highest death rates were West Virginia, New Hampshire, Rhode Island, Ohio, Massachusetts, and Kentucky. So again, we have an ongoing and growing prescription opioid abuse problem. And so I wanted to prompt a little quiz question here. Where do you think the heaviest abusers of opioids obtain their drugs? So I think we're going to pull that questionnaire up to the side here. Let's see. Okay, here we go. All right, so what is the most common source of opioid pain relievers from the heaviest abusers of these drugs? And we have some options here given by a friend or relative, prescription obtained from one or more physicians, theft, or bought from a friend or relative, or bought from a drug dealer. I'll give you just a second to key in some responses there. All right, so we see most people are answering given by a friend or relative or obtained by prescription from one or more doctors. And the answer, as we can see here from this research that comes from Christopher Jones and his colleagues, among the heaviest abusers, which we can see in this right-hand column here, the most common method of procurement was by prescription from a doctor, at least one doctor or more. So when there's more than one doctor involved, we call that doctor shopping, of course. And so we need a policy response to try to get a handle on this problem of people obtaining prescriptions for misuse from physicians. And the principal, perhaps, response at the state level has been to establish prescription drug monitoring programs in the states. So what are these PDMPs, or prescription drug monitoring programs? They're a tool for prescribers to be able to access, to overcome this asymmetry of knowledge of not knowing how many different physicians a patient is getting a prescription from. And the PDMP provides a searchable online database containing a patient's controlled substance prescription history. So these data are uploaded by dispensers as the pharmacies, and then doctors and prescribers can query the databases and try to know how many drugs and what type of drugs their patients are obtaining. So these programs vary a great deal state to state. Some of these variations include who can access the PDMP, so physicians, dentists, physician assistants, and then proxies for the physicians. For example, let's see, all but 5 states currently allow proxies to access the PDMP data. Almost all PDMPs now provide unsolicited reports to prescribers, so if there is some kind of activity that is flagged by the system, it sends a report directly to a prescriber to kind of alert them that there might be some behavior going on that they need to pay attention to. More recently, PDMPs have adapted and become more stringent in ways. States have begun requiring registration for all physicians. So this doesn't require that the physicians actually utilize the data in the PDMP, but it does require that they set up an account so that they could utilize it should they choose to. And some states have gone even further than that. Currently, in most recent years, states have begun to require physicians to access the PDMP information either before issuing an initial prescription for an opioid or in some cases for every refill of an opioid prescription. And now some states are also engaging in interstate data sharing so that patients cannot cross state lines to evade the PDMP. So this is what a PDMP screen might look like. This is a screenshot from the Pennsylvania PDMP, and so you can see that there's lots of information here that could help a physician. For example, physicians can see the types of drugs and the quantity of drugs being prescribed. They can also see if there might be potential bad combinations being prescribed, such as combinations of opioids and benzodiazepines. They can see if there are multiple prescribers that a patient is using and the location of those. And they can also see if there are multiple pharmacies that are being used to fill those prescriptions. Another thing that might be of interest is the method of payment. So if a patient has insurance but is paying with cash, that might be a way that they're attempting to evade detection by not having an insurance claim. And then finally, up here, you can see the active daily MME, that's morphine milligram equivalents. So if somebody has prescriptions that equal more than 100 morphine milligram equivalents per day, that might be a flag to a prescriber as well, that they need to pay extra close attention to this patient. So we have this poll question going off here to the side. Have you ever accessed your state's PDMP if you're a clinician? And if so, did you find it useful? So we have so far 62% people saying that they have never accessed it, 35% saying yes, and it's been useful for informing their prescribing practice. And so far we haven't had anyone respond that they have used it but did not find it useful, so that's good to know. And then finally the last one was I live in Missouri and we don't have a PDMP. We've got some Missourians here, I just see on the board. Missouri is the one state that has not yet implemented a prescription drug monitoring program. So now that we have in 49 states this policy, I'd say it's a good question to ask, what has been the effectiveness of prescription drug monitoring programs when they go into effect in a state? And specifically, I'm looking at how does physician prescribing change after a PDMP becomes operational in a state? I use 3 criteria for whether a state had a PDMP. One would be that pharmacies are required to report their data to the PDMP. The second is that physicians have access to the data. In the past, some PDMPs were strictly law enforcement tools, but that's mostly changed. And also that it was available online. So some older programs that began even before the 90s were fax or telephone based and not very user-friendly. So I only counted a PDMP if it was available online to provide instantaneous access. The data come from Medicare Part D prescribing. These are physician-level prescriptions for different types of opioids, and I have those listed here. And so that includes data on both aged and disabled Medicare beneficiaries from 2010 to 2013. And I looked separately out at all opioid pain relievers, prescriptions for non-opioid pain relievers, to see if there was some kind of substitution from opioids towards non-opioids. And then the 2 drugs that have been most closely associated with the opioid epidemic, oxycodone and hydrocodone, I looked at separately. And then I looked at prescriptions for Schedule II, Schedule III, and Schedule IV opioids, with Schedule II drugs being considered having the highest potential for harm, and Schedule IV drugs considered having somewhat less potential for harm. I studied a couple different policy variables here. One is whether the state had an operational PDMP during the time period. And then secondly, if a state's PDMP statute explicitly does not require the physician to use the PDMP. So currently in 16 states, the statute has language in it that says that the physician is not required to access the program, which could dissuade use and make a difference in how effective the program could be. So I control for that as well. I use the difference in difference regression, which simply means comparing changes over time between the treatment and control group. So it controls for some unobservable variations across states that might account for the differences in prescribing. And I further use physician fixed effects to make it so that I'm looking at average changes in each physician's prescribing before and after a prescription drug monitoring program goes into effect. So here is a map of the U.S. just showing how the status of PDMP has changed in states over the time period that I'm looking at. So I'm looking to compare treatment and control groups. So my treated group are states that implemented a PDMP during the time period, and my control group is states that never had PDMP during the time period. So that means I exclude 29 states that always had a PDMP during the entire period. And so we have 16 treatment states, and you can see the years that those states implemented their PDMP. Those are the ones in different shades of blue. And then my control states are the 5 states that never implemented a PDMP from 2010 to 2013. And then the stars, the little asterisk there, show the states who have that language in their statute explicitly not requiring physicians to access the PDMP. So here let's skip to my results and see what this shows about the effectiveness of this program, these programs, state by state. So this graph shows the coefficients of the regression models and the 95% confidence intervals. And because the outcomes are log transformed, the coefficients can be interpreted as the percent change in prescribing following implementation of a prescription drug monitoring program. So on the top are the coefficients for if a state has a PDMP, and on the bottom are the coefficients for the effect of a state that has a statute that does not require physicians to access the PDMP. So effectively, the top results are for the effect of a PDMP where a state does not have such language in its statute. And to know the effect of a PDMP in a state which does exempt prescribers from use, you would need to add the top results and the bottom results. So what do we see? The most substantial result right here, we see a 5.2% decrease in prescriptions for oxycodone-containing products. Other significant results are a 2% decrease in opioid prescribing overall and a 2.8% decrease for prescriptions involving hydrocodone. Otherwise, we see mostly insignificant results. I don't see significant changes in non-opioid painkiller prescribing. That would be here. So not any evidence of substitution away from opioids towards non-opioids, though many of the non-opioid pain relievers are available over the counter, so that might be influencing that result. And some limited evidence suggesting substitution towards lower Schedule 4 opioids. If we look at the bottom, we see that these results are essentially mirror images of each other. Where it's negative, it's almost the same amount positive for the statute variable. And what this means is that in states that explicitly signal to physicians that the program is voluntary, it seems to be discouraging use because the PDMPs have no effect on prescribing in states that have statutes that explicitly exempt physicians from utilizing the program. And so this interpretation comports with a study by Kreiner that showed that among doctors that had at least one controlled substance prescription, only 35% had even registered to be able to use their state's PDMP. So there's been substantial underuse of prescription drug monitoring programs. And in states where the state is sending a signal that these programs don't have to be utilized, that might be reinforcing that message. So what are some of the takeaways from this result? The PDMPs have become effective in some ways in targeting towards the most high-profile drug in the opioid epidemic, and that would be oxycodone. However, overall, the effects are small and not very robust for opioids overall and hydrocodone. In other specifications, these results did not persist. I will say the oxycodone result was more persistent. So I would say that it's really a limited result towards oxycodone. There's little evidence of substitution towards non-opioid pain relievers and maybe perhaps a little bit towards Schedule 4 opioids. And these observed decreases where they exist in prescribing were very small relative to past increases in prescribing that we've seen. So here we see a 5% decrease in oxycodone prescribing, but if you compare that to a 175% increase in oxycodone consumption since 2001, that seems like a very small change. This study also shows us that policy details matter. PDMPs had no effect in states where physicians were explicitly not required to access them. So there needs to be a strong signal that access is beneficial and maybe even required. Other studies have found similar results to this, finding either small or zero effect on PDMPs on prescribing consumption. However, some very recent studies have been able to look at the states who only in the most recent years have mandated PDMP access for prescribers. And those studies do find that in states that do mandate access, there is a larger effect. So combined, these findings point to our need for stronger and more binding PDMPs, but that alone is not going to really substantially try to decrease this problem that we have. We need additional policy responses. Some of those might be integrating PDMP data with health information technology to try to make it easier for physicians to access the PDMP and to make those access of the data simultaneous with the actual prescribing decisions. We need to reimburse physician time spent consulting on addiction. Again, I mentioned more and more states are attaching some kind of mandate to their PDMPs, and so making those more robust could make them more effective. The CDC guidelines that came out for prescribing for chronic care are calling for shorter prescriptions and other pain management strategies. And finally, there could be mandated training for all doctors in addiction, and we need to have greater access to substance abuse treatment, as Dr. Blank was talking about, including medication-assisted treatment such as buprenorphine. This problem is critical. It continues to grow. Non-medical users of these drugs are transitioning to heroin and illicit fentanyl, and deaths are rising sharply. So we need to be doing everything we can as a policy community, as a practice community, and as communities overall to try to address this problem from multiple dimensions. But thanks very much.
That all of the guidelines that I have reviewed explicitly exclude people who are having end-of-life medication for palliative or for cancer treatment. These are conditions that clearly are able to be up to the prescriber's discretion and knowledge to be able to manage these cases. So they should not at all affect.
Yeah, I'll second that. Not only are those regulations or those types of patients exempted from many of these regulations. For example, in states that do mandate access to the PDMP, that is only for the treatment of chronic pain and not for cancer pain. So the hope would certainly be that for palliative care and end-of-life care, that these policies would not be a hindrance to effective pain management. In a separate study, I did look at this question specifically to see if there was some kind of secondary negative spillover effects into pain management outcomes, and fortunately did not find that. And I mean, you could say that's to be expected since we're not seeing very much effect of the PDMPs even on its first order effect of trying to limit inappropriate prescribing. But I will say that I think that the rules and regulations and that have been put in place to try to get a hold of this abuse problem are not having substantial spillovers into the real legitimate needs for these drugs.
Thank you. That's, so in thinking about this, I think you guys bring up a really good point. There are different kind of avenues for preventative measures in different laws and rules and policies for different populations. So just like you're saying, both of you are saying that all of the policies that you know do not affect terminally ill folks. I'm wondering if you see any policies or what the impact is of the way we're currently managing the opioid epidemic across socioeconomic lines. Could you, both of you speak to that a bit?
Well, certainly the UCLA study, which I referenced in my talk, clearly shows that unfortunately the most likely people to die who are in this population are folks of lower socioeconomic class and also people of color. They're much more likely to have difficulty accessing care. They're much more likely to have difficulty having finances and insurance and adequate insurance coverage to be able to access the addiction treatment. It also appears that they're much less likely to get referred to treatment. So this is a huge problem and one that really needs to be in the forefront, not just for prevention, but also for providing avenues for treatment.
Thank you. Thank you. We also got another question in real time. So the previous questions were previously submitted questions, so thank you for taking the time to do that. So folks are also wondering who makes it mandatory, who mandates the PDMP and organizes and structures that system?
So that would be a state legislative action normally. I suppose depending on how the original PDMP statute was set up, it could be part of a rulemaking process, but quite often the state legislature takes some action to change the PDMP such that it's not a voluntary program, but one that physicians are required to access.
Mm-hmm. Mm-hmm. And speaking about the different players and who's kind of in charge of what and who's in what role, we also got the question around the role that Big Pharma plays in addressing this issue on the national level. Do either of you have thoughts or research in that area that you'd like to share?
I know in my work down at the legislature here in Georgia that Pharma was very interested in funding some of the PDMPs, and I think in some states there is funding for the actual management. This is an expensive proposition, and so I know that there has been some overtures, at least here in Georgia, there were, to have Pharma be part of the solution. I think, well, that's all I'm going to say.
You know, it's interesting that you say that. There is kind of anecdotally, there's a commercial that's been running. It's a pharma ad, and it is a new prescription that helps relieve opioid-induced constipation. And really scientifically, all the prescription is doing is reducing the amount of opioids in your system. So you could arguably get the same benefits by just reducing your opioid intake. So I know the question always comes up around that. Are we substituting kind of one issue for the next as we looked for pharma-headed ways to combat this pharmaceutical reliance issue? Your thoughts around that?
I think it's...
Yeah, the famous Super Bowl.
Yep.
But yes, I think it is very difficult to look at this.
Yeah. I think the one thing we can all agree on is it's a very multifaceted problem that's going to take a kind of multifaceted, multidisciplinary solution.
Yeah, I agree, and I think maybe what Dr. Blink was refraining from saying about pharma involvement is it's just how it's a double-edged sword. When, for example, if you have pharma companies involved in some kind of regulatory process with the FDA or at the state level, then you have concerns about conflict of interest arising and some public outcry against that. So you know, it's difficult to both involve the drug companies in this process, but also make sure that we're operating in the public interest and not in a company's private interest.
Yep. Very, very complex issues. We're getting another live question asking, what are you guys seeing in terms of the State Department's providing proof of MDs not following regulatory and prescribing practices, or PDMP monitoring practices. The question is really asking, are folks being sued or losing their license? Are we at that point yet? So by folks, I mean doctors. MDs, are they being sued or losing licenses for not reporting adequately in states that require reporting, or poor prescribing practices?
I actually don't know the answer to that.
I know this is a big fear it's a big fear among the physicians that this is going to happen. And since Georgia, the original language in the first bill that was dropped regarding the mandatory checking of the PDMP had actual criminal and civil penalties associated with it. That unfortunately got out into the media, as it should, and most of the physician organizations in the state of Georgia opposed the mandatory use of that PDMP because of the criminal charges. So I think there's a lot of fear among doctors that it's going to happen. To my knowledge, it has not happened. I think that it can be a red flag, and there may be other issues associated with that particular practice, and that they may be investigated by their licensing board and or the DEA, but to my knowledge, that has not actually happened.
Okay, thank you. And I'm getting another question about the differences in, asking if the two of you are able to speak to differences of opioid strength for synthetics and non-synthetic opioids.
You know, it's interesting, an opioid is an opioid, and one of the things that I clearly know with my patients is that they will take whatever dose they need to take to get the reaction that they are looking for, or to stave off the symptoms of withdrawal that they're looking for. So in terms of, is there one that is safer or less safe, they all can be involved in overdose deaths. They all can be misused. And if they are a lower morphine equivalent potency, the patients just use more. Or they'll use a different method. They'll go from taking it orally to using it intranasally or intrarectally, to smoking it, to using it IV. So the delivery method may change, the number of pills may change, but they're able to figure out, these guys are really good pharmacologists, and they know what they're taking, and they know how much they're going to need to take from the prescription opioids. That's the beauty of them for them. That's the deadly nature of, unfortunately, when they are no longer able to access it, either because their doctor won't write it or because they can't afford it, and they move to heroin. They have no idea the dose that they're getting. They have no idea the purity or the impurity. They have no idea whether it's laced with fentanyl or it is just plain fentanyl. So their ability to regulate their dose is Russian roulette, hugely Russian roulette, unfortunately, and that's where we're seeing so many increased deaths.
Okay, so hi, this is Steve Emily. I'll follow up on that, and with a general question. They're moving to like heroin. Are we looking at root causes and why people are taking these opioids and how to address those particular situations?
Well, there are plenty of people out there who can use opioids and take them without having any difficulty. The people who are likely to move from a prescription drug to heroin are either patients with poorly treated chronic pain and or people who have the genetically inherited disease of addiction. And in the one case, it's a pain issue that has brought them to the table. In the other case, it's a genetically inherited disease that needs formal treatment, needs to be identified and treated. And that's the difficulty. Certainly, the role of trauma or co-occurring disorders plays a role in the treatment plan, but the disease of addiction is a childhood brain disease. It's a genetically inherited disease, and these folks need to be identified and treated, or we're going to see the same merry-go-round. That does not mean, however, that plenty of people can't get themselves into trouble by using these drugs recreationally or using these drugs inappropriately with or without the disease of addiction. They can still die, they can still have liver damage, they can still have significant overdoses and other complications. So it is a major health crisis, but the ones that are going to be moving on to heroin have usually significant pain that is not treated or the disease of addiction.
Yeah, exactly.
In my opinion.
Yeah, exactly. I agree with you. And, the question begs, are we as a country treating those properly? Because the policies and the techniques seem very broad-based across the board. Like tracking, physician, prescription, patterns, right? And these days, all physicians now are just, they might not say it, their behavior indicates they are afraid that they're going to get on the blacklist.
You mean the blacklist as getting poor ratings, for example, if they're not treating their patient's pain effectively, or if
exactly.
they're reporting that? Yeah.
Exactly, or having their license reviewed, or whatever the case may be. They know that data is being compiled in those categories, and they're sensitive to that. So, are there other ways to be able to allow the physicians and encourage them to change their practices, in terms of these root causes, right? Digging deeper into the root cause, like you guys just mentioned, some of them are, patients that are, chronic pain patients, or in one of your slides it indicates, overdoses dealing with cardiovascular or even cancer, right? So there are options, out there, and really changing those care plans.
Yeah, I think, so much of what we talk about when we talk about health reform in general is how are we incentivizing different behaviors from physicians, and it's something worth looking into is how are we reimbursing physicians, for example, for taking the time to develop these care plans, implement them, and then to do proper counseling when they suspect that there is an issue. I think that we do need to look more carefully at that incentive structure, and it's not only just sticks involved, but there are also carrots to try to encourage physicians to be more attentive to the potential effects of these drugs for some subset of their patients.
Okay. All right. Well, it looks like we're coming to the end of our time. We weren't able to get through all of the submitted questions, but if you have further questions, the contact information for all of our presenters is available to you, as well as the PowerPoint presentation itself. Yes. I want to thank everyone so much for your time and your participation, and we look forward to seeing you on the next webinar series.
We thank each of you for joining today's webinar. And we want to share with you our upcoming June webinars. So here we have our webinar calendar, and each of you will receive in your emails an outline of our June webinars. I'd like to take this time to thank Dr. Blank and Dr. Yarborough for extending their expertise to facilitate Topic 1, our policies for reducing opioid addiction, impact and care in your community and clinic. Again, the webinar presentation is available to download, and a link to the webinar webpage is also located at the bottom lower field. You can again connect with us at PriCare Matters or via our website at www.primarycarematters.org. We thank each of you for your attendance, and we hope that you have a wonderful afternoon.